1, 2, 3, hello. This is Ortho Barista, where you can learn orthodontics easily over a cup of coffee. I'm your senior Ortho Barista, Ji Dae-kyung.
I'm your junior barista, Lee Jong-guk. Is it my turn? Sorry.
It's okay.
In the previous session, we explored clear aligners.
While enjoying clear machi,
We introduced simple cases for clinicians. I wouldn't call them just simple. They were, rather, relatively simple and easily accessible cases.
this time is more about advanced cases. What's the most advanced case you have dealt with using clear aligners, Dr. Lee?
I will share cases regarding an open bite and molar distalization today. How about you?
It is a secret.
But I told you already.
Since you mentioned an open bite, I will share a deep overbite case, as it was briefly shown in the simple case session.
So you brought a deep bite case?
Yes, and then another one about horizontal overlap. Last time, we only talked about an overjet, but this time, I will cover an overjet in Class 2.
There you go. I also have a Class 2 case.
Do you?
Yes, it is about molar distalization.
Then, let's go. Let's take a look. The first case is from me. See, there it is, a bit of distalization.
That's same with mine.
Yes, there are vertical issues. This is an adult patient, and she came in with a complaint of misaligned teeth and teeth seemingly slanted inward.
Lots of teeth movements seem necessary.
Definitely.
Left and right are not symmetric with a deep bite.
And then significant linguoversion on the maxillary anterior region. And if you look at the left side, it is nearly a half-cusp Class 2.
This is quite extreme for the first case.
Are you getting anxious?
Yes, definitely. This can be quite challenging even with brackets.
Yes, that's right. So, as I've said before multiple times, for a deep bite case like this, brackets cannot be applied on the mandible. It will inevitably be time-consuming, and it will eventually require additional appliances such as ABP. You can probably get those points in the cephalometric image, too. So, this is Class 2 Division 2. These are the diagnosis and treatment goals that I have set. On the case diagnostic analysis, as mentioned before, you can see the comparison before and after setup and expected steps and treatment time, etc. For this patient, well, there were many things to consider such as teeth movement. So, the analysis files went back and forth about 4 times. That is why, to some extent, you need to have an understanding about teeth movement. With that in mind, you can place an order. For this one, I did IPR and proceeded to the next step. There is one thing to consider here in theory. This is same for bracket-based treatment. For a deep bite case, maxillary anterior teeth should be intruded. Usually there are cortical plates on the buccal and labial sides. Interference with these plates can result in issues including root resorption.
I need to mark here then.
Thank you. That's a great help.
This is labial plate, not lingual.
So, with this lingual version, labioversion proclination should come first, followed by intrusion. And if necessary, retraction can be done. You can consider following these steps in bracket-based treatment, too.
So, proclination first, and then intrusion and retraction.
Right. That's my tip.
So, you need to keep this in mind and
share this when placing an order. You can let the manufacturer know of these steps, because manufacturers will not pay much attention to the cephalometric images. So, you can leave comments about the plate root proximity and the mandibular symphysis width, etc. for the order, as mentioned by Dr. Lee the other day.
I think making such comments is really important. But it seems that others don't, but I believe that really matters.
So for this one, I delivered 6 aligners in the first phase. The deep bite was quite significant. It may not be noticeable now. But if you look at the anterior region, you can see a little bit of the cervical region beneath.
Is this in the third month?
Yes. No, it is not the third month. For this patient, I let her wear aligners for 10 days, thus it is 60 days after, 2 months later.
Yes, 2 months on then.
So in the overlapping comparison, you can see the intrusion amount. And on the mandible, with proclination, a little bit of expansion can be checked here. So, after a certain period of time, I began to place class 2 elastics on the left side. And as I mentioned about class 2 elastics before, maybe in the second session, I let a patient wear them early on if possible and not force the patient to wear them full time from the start. They can start to wear them in the evenings first and then increase the wearing time little by little based on how cooperative they can be. This is after applying the 12th aligners. This is the upgraded Magic Align.
Yes, I can see that.
There are markings and gingival line cutting as well. Do you know what that is?
Is it a bite ramp?
Yes, it is a bite ramp.
It is written there.
Yes, that's right. As you can see here, a routine for anterior region is to apply a bite ramp from the lateral incisor on one side to the lateral incisor on another side. But in the case of class 2 division 2 like this one with lingual version, due to the bite force, trauma, or something like that can be applied on the maxillary anterior teeth. Thus, some will apply the bite ramp from canine on one side to canine on another side.
Do you usually use a bite ramp for a deep bite case? Or do you have any specific standard?
About that, I can say that usually the decision will be made by manufacturers. As far as I know, if the amount is about 2 mm to 3 mm, then manufacturers will usually produce the bite ramp as a routine.
So, you are saying that if the intrusion amount is 2 mm or 3 mm, patients will usually have to wear the bite ramp.
Right, so when the curve of SPE is a little deep, or when the mandible needs more intrusion, and if we are to induce extrusion of the mandibular premolars, and if the angle is low, I try to consider those things when I have to make orders on my own.
Don't patients find them uncomfortable? They seem very uncomfortable to me.
I think that some even don't notice them. If you think about ABP, you might think that they will be uncomfortable. But patients have already gotten accustomed to having aligners elevated a bit due to the wafers. So they don't have any particular issue with a bite ramp.
With a ramp, it is definitely good. In the case of a deep bite, if the posterior region is intruded, then it may result in a bad way.
Exactly.
And as the clear aligners themselves are using push force. That is why this bite ramp can come in handy.
Yes, I think they are really useful. So, let's take a look at the reaction, then. This is the second set of aligners. After wearing 12 of them, you can see more exposure on the lower side. And with the class 2 elastics, half-cusp difference has been reduced little by little. Spacing on the mandibular dentition is due to proclination of mandibular anterior region. And the maxillary posterior region spacing is caused by a bit of distalization. So if you look at here, you can see some spacing on the maxillary anterior teeth. With distalization, the mandibular posterior teeth are rather actually being pulled a bit forward. And now with the class 2 elastics, it opened quite a lot, right?
It did. It opened a lot more.
Now it is the status in September. It is not yet finished. This is the status in the 10th month. I think the overjet and overbite have greatly been addressed.
In addition, it is very encouraging to see that with the tooth axis correction, intrusion was done to the maxillary central incisors.
Yes, it looks good. And on the left side, you can see that class 2 key has improved both in posterior region and canines, albeit not perfect. There has definitely been an improvement. Actually, I can talk a lot about this case. For molars, if we are to induce distalization, there will be some side effects. More details may be covered by Dr. Lee later. Anyway, in this case, those side effects were rather taken advantage of.
Right, that can be one way of seeing this case.
Moving on to the pictures of number 12 teeth on the maxilla, this is a microdontia. Rotation is severe there. It was difficult to address this only with aligners, so I attached additional appliances.
I can mark it here. Here is a button, right?
Yes, that's right.
A button, a lingual button has been attached to the tooth, and is this a power chain?
Yes, it is a power chain. And also on the labial side.
Yes, so it is like applying force couple here and here. This is a button attached to the appliance, and this are attached to the teeth.
If you want to attach a lingual button to the aligner, it takes a lot of efforts. So you can include the request in the ordering, but to the teeth, you have to attach them for yourself. And when placing an order, you have to make sure to request a cutout on the area where a lingual button will be attached.
Then, can patients place rubber power chains on their own?
At first, we usually let them wear an elastic of 3/16 of an inch. Usually, it will be a rubber band. But given the tension of a power chain, we usually use power chains for bracket-based treatment, thus I tried that way. Even if they are good at placing the power chains at clinics, they may find it hard wearing them again when they are on their own.
That does not seem easy.
That's why I changed it. So, as for the routine, I changed it to a 4-ounce elastic with the smallest size of 3/16 of an inch.
I really love the idea. If we used aligners only, this would take a lot of efforts for rotation.
Exactly. Or it might not work.
Right.
This may mean that we were that much desperate to find a new solution. Anyway, if you look here, this has been about 10 months. It's not bad.
Actually, it looks really good.
So, as you mentioned earlier, on the maxillary and mandibular anterior region, we did tooth axis proclination, and after the change form class 2 key to I key, followed by rotation control and so on. About the overjet and overbite, the status now seems quite good, doesn't it?
Wow, this shows clear aligners really work.
Yes, it looks good. You can see the proclination of the maxillary anterior teeth in the occlusal surface. Now to the second case. I cannot say which of the two cases is more difficult. This one also has a deep bite and is a bit similar to class 2. The extent of division 2 is less severe than the first one. We can say that this is a full cusp class 2 also with a deep bite. Have we checked the panoramic X-ray before? You can see here that this case has a low angle, making it challenging even for bracket-based orthodontics. So, there actually is a tip to attach a button. Dr. Lee shared this tip. Thank you for that.
No problem.
I make a lingual button by using an O-ring or a separation ring.
It seems like it might fall off, but it doesn't fall off easily.
No, it hardly falls off. When you attach the ready-made clear button, it actually falls off too easily.
It really does.
So, anyway, I started using class 2 elastics almost from the beginning. As you can see, in order to correct the deep bite, a bite ramp was applied over the anterior region from lateral incisor on one side to lateral incisor on another side. And these are indications for this approach. For this patient, while applying class 2 elastics, I started to proceed with molar distalization, especially for the maxilla. In fact, class 2 elastics are mainly for class 2 correction, but in this case, it can also prevent the counteraction to molar distalization. These are so-called butterfly teeth, aren't they?
Yes.
And correction does not seem easy. So if you look at July status,
there has been much improvement in the bite.
Right, I think it is really good for addressing the deep bite. It really is. The full cusp class 2 has not yet perfectly been addressed, but if you look at the posterior region, you can see gradual improvements. And there is some space on the areas in front of the number 6 tooth. But by narrowing down the space little by little, class 2 key will be addressed.
Right.
So for this patient, we spent about 9 months to treat the issues. You can see somewhat improved class 2 key and alignment as well as correction of the tooth axis and the deep bite. That is why we can expect more for the next 9 and 10 months.
Yes, considering it has come this far, I think it will finish very well.
So, once I am done with this case, I will introduce the case next time to see which one is more advanced, yours or mine.
I am looking forward to that. I have a question here. As for a deep bite, I cannot remember when it was. But maybe in the first session, I mentioned pushing force. Clear aligners are about pushing force. Thus not just the anterior teeth, but also the posterior teeth will be pushed down. That is why I thought at first that it would be hard to deal with a deep bite with clear aligners. Because of the occlusal force, clear aligners might be better for an open bite.
It is so true.
In the case of a deep bite, due to the occlusal force, posterior region will also be intruded.
Right, definitely.
So, what do you think about that?
Right. In fact, in that sense, we had been actually a little reluctant to apply clear aligners to a deep bite. But now it seems that paradigm has been shifting little by little from the early version. In particular, there have been advancements in material characteristics used in clear aligners, such as attachments. Do you remember that thing, Chewies from Company I?
It is something to chew on.
That was same with Korean manufacturers as well. This is because at that time there was nothing like attachments or supporting appliances.
It will not perfectly fit.
Yes, so we needed something to push aligners down. Then, there will be excessive bite force on the posterior teeth.
Yes, that's right.
But now, I think we can deal with the intrusion force on the maxillary anterior teeth only with a setup to some extent.
Unlike in the past, now I became to think that clear aligners can work for a deep bite as well. First, you cannot place brackets on the mandibular anterior teeth.
Yes, that's right.
So, to deal with that issue, you need to do a lot of work. So in that sense, this can be quite a good solution.
Okay, then let's move on to the next one, an open bite case that you briefly mentioned in the beginning.
Actually, for an open bite, rather than clear aligners, I mostly used brackets for treatment. I believe that an open bite is not about treatment, rather it's about retention. It hasn't been that long since I used Magic-Align, so I don't have enough information about retention. But retention is an issue not only in clear aligners but also in bracket-based orthodontics. There are actually no studies suggesting that the possibility of relapse is higher in clear aligners. Rather, there have been studies that relapse possibilities are similar in both treatment methods. Maybe I have some chance to go deeper about retention next year.
Yes, hopefully.
So it would be better for you to consider retention as well. When it comes to an open bite, I generally see it as having 3 major categories, and I will explain each of them. This is a relatively simple open bite case, and I believe that the cause of the open bite is important. Based on the cause, the treatment approach can be completely different, such as whether the causes are skeletal or odontogenic issues. For this case, it may seem that a COCR discrepancy exists.
Right, so it might be hard to apply clear aligners.
Yes, exactly. That is why I think that diagnosis is important. If a COCR discrepancy exists, I should establish my treatment strategy accordingly. The concepts will be extrusion of anterior teeth, intrusion of posterior teeth, or both of them. For this case, it has a slight overjet and also has an open bite. Fortunately, there was no COCR discrepancy. So I made a simple plan to distalize the anterior teeth. In the previous session, you showed how the vertical aspect was well controlled, and the anterior teeth were moved inwards. In this case, the anterior teeth were actually distalized with slight extrusion, which is a great outcome. So, I proceeded with the treatment. Based on a panoramic X-ray, I could see that this wasn't a severe skeletal open bite. First, let me clarify here. I think that distalization mostly accompanies extrusion. Unless we take a really strategic approach, taking the teeth in parallel backwards is really difficult. Moving teeth backwards itself is great. If we can address at this level, it is a success for clear aligners. For second, posterior teeth will be moved up while the anterior teeth will be pushed down. I think this concept is quite common in clear aligners, and the one before as well. For third, posterior region only will be moved up. This is very hard to expect in clear aligners. I mean, unless we use mini screws, this kind of movement is really difficult. So, the first two cases, extrusion of anterior teeth or intrusion of posterior teeth accompanied by extrusion of anterior teeth, are the most common movements we can expect in clear aligners without special screws. And I would like to briefly share this case. For this one, I distalized posterior teeth after stripping, and surprisingly, as I showed earlier, it worked really well. It worked well, and regarding retention, of course the approach can vary according to causes, but using the extrusion that will come along with the distalization of anterior teeth can be one of the approaches. This case seems a bit more complex. There is an overjet.
And crowding as well.
So I had doubts about whether it can be really solved with clear aligners. I had doubts, and if you look at the cephalometric image, there seems to be some signs of a skeletal open bite. So, for this case, which approach should be taken? Extrusion of anterior teeth? Intrusion of posterior teeth, or both of them? First, intrusion of posterior teeth seems necessary and for the anterior teeth, as teeth will be distalized. So by using that, a little bit of extrusion might not be bad. I mean, regarding how much the inside will be shown. By the way, for an open bite, I always believe that posterior intrusion is the main movement. Extruding the anterior teeth is something I do cautiously because if they are extruded too much from the gum bone, there can be periodontal issues. So, I'm very careful about extrusion. But in this case, I thought some extrusion was necessary. And these are photos that I had taken at each step over months. You can just check the bite closing. I've checked the progress in 1, 3, 5, and 8 months. I was able to see that the bite has closed down very well. There is more complexity, like extrusion and distalization of anterior teeth and intrusion of posterior teeth, not just about posterior intrusion. Of course, on the simulation, design is more focused on intrusion of posterior region, but in fact, without using screws, I think you can never have the posterior teeth intruded more than the anterior teeth. I've overlapped before and after X-rays. There can be some errors as I did this overlapping only on PPT file. But you can see this much change. You can see a little bit of counterclockwise rotation on the mandible. And here, you can see slight intrusion of number 7.
Right.
And by using that, the mandible has closed down, along with distalization and extrusion of anterior teeth and slight extrusion of mandibular anterior teeth. When we plan to apply clear aligners for an open bite and a deep bite as well, you have to consider whether a patient is a minor, still growing up, or an adult.
That's right.
For a deep bite, there can be various approaches depending on how much extrusion you want to induce or whether a patient is an adult or not. But I let you know that I am sharing cases targeting adult patients. As for clear aligners, the plan will mostly be like slight extrusion of anterior teeth and slight intrusion of posterior teeth.
And when it comes to open bite cases shared so far, by the way, for a deep bite, the question is whether or not to place clear aligners, and if so, when to place them. And it could be a bit difficult at first. For an open bite, however, especially for a patient with slight class 2 or with a convex profile, I was always less confident.
That is so true.
Dual bite is difficult, too.
Right, and depending on the condition of a condyle, things can be more intimidating. Those cases are more challenging ones. But fortunately, the case I just showed had no jaw-related issues or instability.
But still, for the second case, you might have concerns about what I should do if they will be intruded too much. But anyway, you did a good job.
Actually, depending on situations, I will have to set up strategy accordingly, and all orthodontic treatments cannot be completed as planned.
Don't you have that case? I mean the case mentioned in the previous simple case sessions, where IPR was done and torque was adjusted on the maxillary anterior teeth?
Right.
By doing so, you pushed them down.
Yes. And one more to add, as you know, it is not easy to induce intrusion of posterior teeth for an open bite only with aligners.
Definitely not easy.
This is how most treatments are done. We install screws both on the lingual and buccal sides, and a patient will wear a rubber band. Then with the force of a rubber band, posterior region will be intruded naturally. But in most cases, the closing will not be perfectly done. Eventually you have to use a button like this. Only with aligners and rubber bands, we can induce intrusion of posterior teeth to some extent, closing the bite on the anterior region. But eventually we have to use a button like this to stabilize the rubber bands. Of course, we will have to keep an eye on the progress of treatment, including the possibility of relapse. But I just wanted to say that we can take this kind of approach. That is all for an open bite case.
So in summary, the concept is like this. While inducing intrusion of posterior teeth, you can perform some IPR on the maxillary anterior region and adjust the torque while closing the bite, isn't it?
Right. Actually, this patient had a relapse before. She suffered a relapse after having gone through all the difficult open bite treatment. She didn't want to have brackets. So, I chose this approach, and this is currently in the retention phase. It has been 6 months now since the treatment was finished. So far, retention looks good.
By using screws like this, unlike in bracket-based treatment, we can distribute the forces through aligners. I think that is a very good idea.
Yes, that's right.
Today, we examined together advanced cases where orthodontic issues are all mixed up, especially a deep bite, a deep overbite, and a severe open bite. How did you find it? What do you think about the future of clear aligners?
I think we are now going through trial and errors when it comes to clear aligners, and there are many advanced and complicated cases we are currently dealing with by using Magic Align. For many cases, treatment is not yet completed, so I cannot open the results right now. But probably by next year, I think we can share the most recent Magic Align cases.
Right.
Of course, it is not like we can deal with all the cases only with clear aligners, but I believe we have to come closer to perfection as much as possible by going through the trial and error phase.
Don't you think more clinicians want to learn more about clear aligners and Magic Align after today's session? At the very least, if more people have been encouraged to learn more, I think that itself is quite an achievement for today's session. What if some want to have more deep dive sessions?
Well, do I have to put some coins to move to the next level?
For those who want to learn more about clear aligners, we have one-day seminars ready for you. We are now touring across the nation. If the date or the place suits you, please join us, whether it be Seoul or Daegu. Then you can get more information from there. We started today without desserts.
Oh, did we?
Maybe that is why I felt something was missing.
There should have been some sweets we can enjoy.
Anyway, I hope that you enjoyed our session today, just like sweets. Have a great day, as always.
Thank you for watching. Thank you.